Good afternoon, everybody. As stated before, my name is Jeffrey Ling. I'm a surgical resident at Eisenhower, and it's a pleasure to be able to speak to all of you today. Now, starting off with our disclosures, we have no relevant financial interests, arrangements, or affiliation with any commercial interest related to the content of this activity. So for a little bit of background, there's been some debate over the last few years about the utility of mechanical bowel prep alone and prior to elective colectomy. However, it's been shown that the combination of oral antibiotic prep and mechanical bowel prep has had a number of benefits, including decreased rates of anastomotic leak, as well as decreased rates of surgical site infection. However, despite this benefit, there's been some concern raised that the addition of oral antibiotic prep prior to an elective colectomy can potentially increase the risk of C. diff infection. And this makes sense based on what we know about how C. diff infection develops by the kind of decrease in intraluminal native gut flora, leading to the decrease in colonic resistance to C. diff infection. And this is a potentially catastrophic complication for our postoperative patients. It can lead to increased morbidity, increased mortality, as well as potentially an increased length of stay. So it's definitely in our best interest to try to avoid this if possible. Some studies have been performed showing that there's actually an increased rate of post-colectomy C. diff infection, whereas others have shown that there's no significant difference between the two. So to that end, our objective was to identify the impact of oral antibiotic prep on the rates of C. diff infection in elective colorectal surgery. To accomplish this, we performed a retrospective review of approximately 64,000 patients from the 2015 to 2016 ACS-NSQIP database. We started with approximately 64,000 patients, and we used the exclusion criteria of emergent cases, non-prepped patients, and patients who received oral antibiotic prep alone. This left us with approximately 24,000 patients. We further separated this out into patients who received a combined bowel prep, meaning both oral antibiotics and mechanical bowel prep. This gave us approximately 16,000 patients. This, again, left us with about 8,000 patients who received mechanical bowel prep alone. Looking at our results, what we found was that for the rates of C. diff infection, with mechanical bowel prep and oral antibiotic prep, there is a statistically significant decrease in the number of C. diff infections, with approximately 1.12% for the combined group compared to 1.95% for the mechanical bowel prep alone group, with an odds ratio of approximately 0.58. We also saw statistically significant decreases in the rates of anastomotic leak, as well as the rates of ileus and surgical site infection, which is consistent with previously reported data. In addition, we were also able to look at some of the more systemic signs of infection, namely sepsis, septic shock, and mortality. And what we saw in these cases, again, was that there was a statistically significant decrease in the number of the sepsis, septic shock, and mortality with the addition of oral antibiotic prep to the regimen. Now, there are some limitations associated with our study. For one, there are some limitations inherent in using the national NSQIP database in a retrospective fashion to harvest our data. In addition, we saw that there was some significant heterogeneity between the two groups that we studied. For instance, our combined group, the group that was receiving both mechanical and oral antibiotic prep, was more likely to have received preoperative chemotherapy as well as preoperative steroids. For our mechanical bowel prep group, what we saw is that they were more likely to have a lower preoperative albumin as well as preoperative weight loss, diabetes, and malignancy. So because there is kind of this heterogeneity present in our two groups, it does make it a little harder to draw definitive conclusions based on our data. In addition, because we are using the NSQIP database, we're unable to really delineate what kind of oral antibiotic prep our patients were receiving on a case-to-case basis. So for summary and conclusions, what we saw based on our data was that there are potentially decreased rates of C. diff infection, potentially decreased rates of sepsis, septic shock, and death, and potentially decreased rates of anastomotic leak and surgical site infection, which supports the current literature. As far as why we're seeing potentially decreased rates of C. diff infection, there are a couple of different theories. there may be an association with the decreased rates of surgical site infection. If you have a decreased rate of surgical site infection, you may use antibiotics post-operatively at a lower rate, thereby lowering your rates of C. diff infection. In addition, there may be some unknown change in the microbiome that we're not necessarily able to model in our current research on the microbiome that may lead to this decreased rate in C. diff infection. So that's my presentation, and thank you all for having me here, and I would love to answer any questions that you all may have.